Welcome to this medicine masterclass in which we will be explaining how to perform an abdominal examination. Start by washing your hands, introducing your role, confirming the patient's details and explain the examination to them to gain informed consent. Offer a chaperone, adequately expose the patient and position them semi-recumbent at 45 degrees and explain to them that during the examination you would like to lie them flat. Make some general observations, note any medical equipment such as catheters, cannulas, feeding tubes, surgical drains, sick bowls. If these are present, inspect their contents. Observe the patient from the end of the bed looking for any obvious scars, whether the patient appears jaundiced or if there are some excoriation marks, if there's a visible stoma or hernia, and whether the patient appears edematous or cachectic. Moreover, look for any mobility aids such as a walking stick or wheelchairs. This will provide you an idea of the functional status of the patient and will help you manage the patient. If there are any vital sign charts or fluid balance charts or prescription charts, inspect these to help you determine the clinical status of the patient. Now move on to examine the patient's hands. There are several important signs that you should be looking for in the hands in a gastrointestinal examination. Examine for clubbing. Clubbing involves the uniform soft tissue swelling of the terminal phalanges of the digits with subsequent loss of the nail bed and the nail angle. Causes in a gastrointestinal exam could include chronic conditions such as inflammatory bowel disease, celiac disease, liver disease or cirrhosis, as well as GI malignancies, including GI lymphomas. Leukonychia is an important sign where there is a white discoloration to the nail, and this can be associated with hypoalbuminemia, either as a result of liver failure or a protein-losing enteropathy. Koilonychia, or spoon-shaped nails, are associated with iron deficiency anemia, and this may come about for a number of reasons, including malabsorption or Crohn's disease. Onycholiasis, or painless distal nail separation, can be caused by trauma, thyrotoxicosis, or psoriasis. Other signs, for example palmar erythema, is reddening of the palms at the thenar and hypothenar eminences, and this can be as a result of physiological conditions such as pregnancy, but can also be as a result of liver disease. Dupuytren's contracture involves thickening of the palmar fascia, resulting in the development of cords of the fascia that eventually cause contraction deformities of the finger and the thumb. These can be idiopathic, genetic, as a result of excess alcohol use or liver disease, and can also arise with increasing age, and the male gender is a risk factor. Bruising or coagulopathy, petechiae, can result as a result of liver disease or loss of the synthetic function of the liver or thrombocytopenia. Splenomegaly may cause sequestration of platelets, and that can also result in petechiae. Ask the patient to outstretch their hands and observe for asterixis or a hepatic flap. This is a negative myoclonus and results from increased ammonia levels which are able to cross the blood-brain barrier and affect the normal motor control. Terry's nails are a sign of chronic liver disease or chronic renal failure, and this is where the proximal nail is pale and the distal nail is darker. Also observe for needle track sites. Whether the patient uses intravenous drugs, this may be a risk factor for developing certain viral conditions that can affect the liver. And generally inspect for any signs of excoriations. Scratch marks may be caused by the patient trying to relieve pruritus, which may be driven by an underlying cholestasis. Bose lines, these are in the nails. These are deep groove lines that run from side to side on the fingernails or toenails, and they may look like indentations or ridges, and these can come about due to malnutrition, infection or trauma. A patient may be taking long-term steroids, either as a form of immunosuppression for a liver transplant or a renal transplant, or for an autoimmune condition, including autoimmune hepatitis. As a result, look for any Cushingoid appearances. In the hands, you may note thin skin or bruising of the skin. Observe for a fistula. An AV fistula is a surgically created fistula, and it is used to facilitate hemodialysis. Observe for any thickening, darkening, or a velvety appearance of the skin known as acanthosis nigricans, and this is associated with diabetes or gastrointestinal malignancy. Move on to examine the patient's pulse. Palpate the patient's radial pulse, which is located at the radial side of the wrist, with the tip of your index and middle fingers. Observe for the rate. A tachycardic pulse may indicate sepsis or a compensatory reflex tachycardia as a result of GI bleeding. An irregular pulse may be as a result of atrial fibrillation, which could be driven by an underlying sepsis process. Ascertain the patient's systolic and diastolic blood pressure readings. A low blood pressure may indicate GI bleeding. Now move on to inspect and examine the patient's face. There are several important signs. Scleral icterus, or a jaundice sclera, is most evident in the superior portion of the sclera, so you can ask the patient to look down as you elevate their upper eyelid. And jaundice can be prehepatic, hepatic, or posthepatic. Kaiser-Fleischer rings, these are green-yellow discoloration at the corneal margin. These are readily seen on slit lamp examination and can be suggestive of Wilson's disease. Xanthelasma, or yellow deposits around the eyes, can indicate hyperlipidemia. Ask the patient to lower their eyelid, the lower part of their eyelid, to look at the conjunctiva. If the conjunctiva appear pale, that may suggest an underlying anemia. That could be an anemia of chronic disease or as a result of GI blood loss. Inspect the parotid glands. Parotid swelling can be associated with chronic alcohol use or viral conditions such as mumps. Inspect the oral cavity. Angular stomatitis is an inflammatory condition affecting the corners of the mouth, and causes can include iron deficiency, and that can be as a result of a poor GI absorptions or GI malignancy. Inspect the tongue. Look for any white discoloration. An oral white patch that does not rub off can be a sinister sign known as leukoplakia, and this is a pre-malignant lesion. Oral hairy leukoplakia is a white patch that's usually driven by HIV or Epstein-Barr virus. On the other hand, if you have a whitish discoloration, which is easy to scrape off, that might be as a result of oral candidiasis, a fungal infection associated with immunosuppression, and it's characterized by a pseudomembranous white slough that can be easily wiped away to reveal the underlying mucosa. There are some other signs in the face. Aphthous ulceration inside the mouth may be as a result of inflammatory bowel disease, B12 deficiency or folate. Gingivitis, it's important to inspect the gums. Any signs of gum inflammation or hypertrophy may be as a result of poor oral hygiene, but can also be as a result of drugs such as cyclosporine, which may be given to patients who have had a transplant. Other drugs such as phenytoin and nifedipine can also cause gingivitis. Inspect for any signs of hyperpigmentation. Hyperpigmented macules are pathognomonic for Peutz-Jeghers syndrome, an autosomal dominant genetic or disorder that results in the development of polyps in the GI tract. Pigmentation can also indicate Addison's disease. And note that severe indication or a black tongue can be caused by a fungal infection, Aspergillus niger. A geographic tongue, this is where there's local loss of papillae, as you can see here, that leads to ulcer-like lesions that change in colour, and this is a benign condition. So there are a lot of signs that you can pick up in the face. Move on now to examine the neck. The lymph nodes must be examined carefully in a GI examination. The left and right supraclavicular fossae must be palpated specifically and carefully. The left supraclavicular fossa contains Virchow's node. These groups of nodes receive lymphatic drainage from the abdominal cavity, and so enlargement of Virchow's node can be a clinical sign of metastatic intra-abdominal malignancy, most commonly gastric malignancy. The right supraclavicular lymph node receives lymphatic drainage from the thorax, and therefore lymphadenopathy in this region can be associated with cancer from the esophagus or other thoracic viscera. The nodes that you should also examine include the submental nodes, the submandibular nodes, the supra and infraclavicular, the posterior and anterior triangle nodes, the jugular chain, the pre- and post-auricular, as well as the occipital nodes. Move on to examine the chest. Look for spider nevi. These are central red spots with reddish extensions. More than 5 are deemed significant and can arise as a result of chronic liver disease. Note that if you press these spider nevi, you'll obliterate the redness, and when you observe the refilling, they fill from the center outwards, confirming that these are arteriolar in origin. Apart from spider nevi, assess for signs of gynecomastia, the overdevelopment of male mammary glands, and this occurs as a result of pseudo-feminization. Liver disease can impair the metabolism of estrogen. Estrogen then builds up in supraphysiological levels in the male, and that can cause hair loss as well as gynecomastia. Note there are other drugs such as digoxin and spironolactone which can also contribute to gynecomastia. Now move on to the abdomen. Start by a very careful inspection. Is the abdomen distended? Distension may be as a result of fluid or ascites or fat. As a consequence, the patient will have obesity. They may be constipated, they may be impacted with feces, or flatus, which is not passing due to an obstruction or subacute obstruction, or in a female of childbearing age, you may consider a pregnant abdomen. Observe for caput medusae. These are engorged paraumbilical veins and indicate the patient has portal hypertension. Observe for striae. These are reddish pink or white lines which are as a result of rapid abdominal distension. This can occur due to the development of ascites, pregnancy, or a Cushingoid appearance which may be iatrogenic. Look for any signs of obvious bruising, particularly around the umbilical region. This can indicate a retroperitoneal bleed as a result of pancreatitis or a ruptured aortic aneurysm. Great Turner sign is bruising in the flanks, and this again is associated with retroperitoneal bleeding, such as pancreatitis, necrotic pancreatitis, or a ruptured AAA. Now move on to look for abdominal scars. There are a number of scars that you should be aware of, and in this patient, you can see a well-healed old midline laparotomy scar. So a number of scars that you should be aware of. You can see superiorly a Mercedes-Benz scar. This is used commonly for liver transplantation. Although scars have multiple uses, you should be aware of the names of each scar. This is a right subcostal scar which can be used for open cholecystectomies or hepatobiliary surgery, and if more organs are required to be accessed, for example the pancreas as well, you can have a rooftop incision. If you see this scar with a vertical projection, this is known as a Mercedes-Benz scar. This is classically used for liver transplantation. Here is the midline laparotomy scar that we saw earlier in the patient that can be used for intestinal surgery. Sometimes a specific area is needed, and you can use a smaller paramedian incision. To access the abdominal contents for vascular surgery or aortic surgery, you may see a transverse abdominal scar. Another important scar is the Rutherford-Morrison scar, which is an inverted hockey stick scar that you may see used for renal transplantation. A Lanz incision, which is a small incision in the right inguinal region, can be used for an appendectomy, an open appendectomy. A left inguinal scar may be used for a number of reasons, either a left inguinal hernia repair, it may be used for cardiac surgery, where an aorta may have been implanted through the transfemoral route. A Pfannenstiel scar you would expect in a female who has given birth through a caesarean section. And of course there may be patients with multiple scars, and it's important just to put this together in your mind. The other thing to look for is the presence of any stomas. Now, if you do see a stoma, observe its site. Commonly, a stoma in the left iliac fossa is usually a colostomy, and in the right iliac fossa is an ileostomy or a urostomy. Note whether the stoma is spouted or flush. A spouted stoma is usually an ileostomy or a urostomy, and the way to discern these is to essentially look at the contents. If the content is urine, then a spouted stoma is a urostomy, and if the content is liquid fecalant matter, then that would suggest that the stoma is used as an ileostomy. If there's no spout and the stoma is flush with the skin, then that's likely to be a colostomy, and the effluent is likely to be formed or hard stool. It's important to look for any complications, if in particular whether the stoma has retracted or whether the creation of the stoma has led to a hernia, and here is an example of a large parastomal hernia as a complication. Note that a hernia is a protrusion of a viscus or part of a viscus outside the cavity which normally contains it, and the protrusion is usually a defect in the wall that contains the cavity. There are a number of different types of hernia that you should be aware of, and these are essentially defined by the area that they're found in. So in the epigastric region, you define as an epigastric hernia, a paraumbilical or umbilical hernia, depending on whether the umbilicus is affected. You may see lateral hernia in the lumbar region or an inguinal hernia. Be aware that you may find a Spigelian hernia. A Spigelian hernia is a hernia through the Spigelian fascia. That's a layer of tissue that separates the two groups of the abdominal muscles. That's the rectus abdominis muscles and the lateral obliques. So between them is the Spigelian fascia, and you can have herniation through them. If you do see a hernia, then ask the patient to cough. And you should see the cough impulse transmitted through the hernia. The lump should increase in size, and that indicates that there's a communication between the intra-abdominal cavity and the lump. Auscultate the hernia, and you should hear bowel sounds, and that would confirm that the hernia contains bowel. If, however, you hear a bruit, then that could suggest that that lump is of vascular origin. Palpate carefully the lump and determine whether or not that causes pain. Look at the patient's face to see whether there's any evidence of facial grimacing, and this may suggest that there's a complication. Another important sign, not to be confused with a hernia, is divarication of the recti. Divarication of the recti results from a gap between the two sides of the rectus abdominis muscles in the midline. A distance can be created by stretching the linea alba. That's a connective collagen sheath created by the aponeurosis insertions of the transverse abdominis internal and external oblique muscles. So stretch caused by obesity, increasing age, surgery or pregnancy can allow protrusion of contents through the midline. And that would appear as a small cigar shape when the patient increases the intra-abdominal pressure. Now we'll move on to palpation. There are 9 key regions that should be palpated. The left and right hypochondriac regions, the left and right lumbar regions, the right and left iliac regions. These are the lateral regions. In the midline, we have the epigastric, umbilical, and the suprapubic regions. The demarcation of these regions, laterally and vertically, we have the left and right midclavicular lines. Horizontally, superiorly we have the transpyloric plane, and inferiorly we have the transtrabecular plane. The transtrabecular plane is a lower transverse line that corresponds to the passing through the iliac tubercles. The transpyloric plane, also known as the Addison's plane, is midway between the xiphisternum and the umbilicus, or midway between the suprasternal notch of the manubrium and the upper border of the symphysis pubis. And this transpyloric plane crosses the pylorus of the stomach, D1 part of the duodenum, the hilum of the spleen, the splenic flexure of the colon, the hepatic flexure of the colon, the fundus of the gallbladder, the neck of the pancreas, and the hila of the kidneys. So many important structures are found at the transpyloric plane. So where these lines meet helps divide the abdomen into 9 key regions. You should ensure that when you palpate, the patient is comfortable, flat, and ask them if they have any pain. If they have any pain, examine from the opposite side as far away from the pain as possible. Start by light palpation and then repeat the palpation in a deep fashion to see whether you can elicit pain or any masses. Following the 9 quadrants, move on to palpating the organs, the liver, the spleen, the kidneys, the bladder, aorta, and specifically any masses, and note if there's any tenderness. If masses are present, then ensure that you're able to help determine their characteristics, in particular the location, the size, the shape, and mobility, and whether there's any pulsatility. Determine whether there's any rebound tenderness. That's said to be present when the abdominal wall is compressed slowly, and then when you suddenly release, that results in a sudden sharp pain, and that can indicate peritonitis. Is there any guarding? That's an involuntary tension of the abdominal muscles, and that can be physiological, but can also suggest underlying peritonitis from appendicitis, diverticulitis, or any other abdominal pathology. Be aware of Murphy's sign and Rovsing sign. Murphy's sign is where the examiner's fingers are positioned at the right costal margin at the midclavicular line at the edge of the liver. The patient is asked to take a deep breath, and if the patient suddenly stops their inspiration due to pain, then this can suggest the presence of cholecystitis, and we would say that that patient was Murphy's positive. Rovsing sign, on the other hand, is where the left iliac fossa is palpated and pain is elicited on the right hand side, and this can suggest free fluid peritonitis, but again, these are non-specific signs. Once you've examined and palpated the 9 quadrants, specifically palpate the liver. Start by palpating in the right iliac fossa using the radial side of your right index finger, and as the patient inspires, continue to palpate the abdomen, moving vertically superiorly until you can feel the liver edge. If you are able to identify the liver edge, determine the extension below the costal margin. More than 2 centimeters indicates hepatomegaly. The consistency of the edge, is it nodular or smooth? Is it tender? Is there any pulsatility of the liver? And auscultate. A venous hum of the liver may suggest portal hypertension, and a friction rub could suggest a gonococcal perihepatitis known as Fitzhugh-Curtis syndrome. The spleen palpation also begins in the right iliac fossa but moves in a superior direction towards the spleen. And in healthy individuals, the spleen is impalpable, but if you're able to palpate the spleen edge, then this could suggest splenomegaly. Move on to blot the kidneys by placing one hand behind the patient's back, below the ribs underneath the right flank, and the other hand on the anterior abdominal wall just below the right costal margin. Push your fingers together to see whether or not the kidneys are blottable. If the kidneys are blottable, describe their size, their consistency. Remember that the left kidney and the spleen can be discerned in several ways. The left kidney is blottable, the spleen is not. The spleen has a notch, whereas the kidney does not. The kidney moves inferiorly in a very minimal fashion, and the spleen moves diagonally towards the right lower quadrant. Percussion of the kidney over the kidney area would be resonant due to the overlying bowel, whereas the spleen, due to its relatively superficial nature, results in a dull percussion. The upper edge of the left kidney is palpable and the upper edge of the spleen is impalpable. Move on to the aorta and bladder examination. Ensure that there's no obvious expansile mass. If so, quantify how many centimeters, and if that's enlarged, that may suggest an underlying aortic aneurysm. And then finally, palpate and percuss the bladder to determine whether or not there's any fullness to the bladder. Percussion of the organs should follow, including the liver, the spleen, the bladder, and if there's any abdominal distension, assess for shifting dullness. Shifting dullness is an important test to determine whether or not the distension of the abdomen is caused by fluid. Start by percussing from the center of abdomen towards the flank until the note changes from resonant to dull. At the point that the note changes to dull, you should roll the patient onto the side, wait for half a minute to allow any fluid to distribute, and then re-percuss over the point where the initial dullness was noted. That should now become resonant if fluid was there originally, and that's known as the shifting of the dullness. Auscultate the abdomen. Listen to the bowel sounds. Normal should be gurgling. Tinkling may suggest bowel obstruction. Scant or absent bowel sounds may be as a result of ileus or peritonitis. Auscultate the liver, aorta, and the kidneys for any bruits. Move on to examine the legs. Pitting edema may suggest that the patient has hypoalbuminemia as a result of liver cirrhosis, or a protein-losing enteropathy, or nephropathy or cardiac disease. Inspect for any cutaneous changes, in particular look for pyoderma gangrenosum. This is a condition in which the tissue becomes necrotic, causing deep ulcers that usually occur on the legs and can lead to chronic wounds. And pyoderma gangrenosa demonstrates pathology. That means that a minor trauma or surgical debridement can worsen the condition. This will complete the examination and then offer to examine the hernial orifices, perform a digital rectal examination, examine the external genitalia, thank the patient and ensure that they are made comfortable, wash your hands and present your findings to the examiner. So in this masterclass, we've explained the key features of the abdominal examination, in particular, the introduction, the general inspection and what things to look out for, the many signs that you can pick up in the hands, arms and face, as well as the key lymph nodes in the neck, the things to look for on the chest, the abdominal inspection, palpation, percussion, auscultation, and the key reasons why we do these things, and then the things to look for peripherally. Thank you very much for attending this medicine masterclass.